The last presentation for today's this session is Role of TKI and Targeted Therapies in the Management of Thyroid Cancer. It will be delivered by Dr. Mohammad Ejaz Khan. Dr. Mohammad Ejaz Khan is the Principal Medical Officer serving at PSNM Cancer Hospital, Faisalabad. Dr. please.
Assalamu alaikum. My name is Dr. Mohammad Ejaz. I am working as a Principal Medical Officer and Medical Oncologist at PSNM Cancer Hospital, Faisalabad. Today I am going to talk about the role of TKIs and targeted therapies in the management of radioactive iodine refractory differentiated thyroid cancer. Disclosures none. So the management of radioactive iodine refractory differentiated thyroid cancer is molecularly driven. Whenever possible, and if the patient is affording, and when their TKIs are indicated, so we should get at baseline the molecular profile of the tissue looking for these actionable mutations. For example, we can see that BRAF mutation is present in papillary thyroid carcinoma in more than 50% of the cases. RET gene fusions are present in up to 7% of the cases, and the NTERC fusion are present in 2 to 19% of the papillary thyroid carcinoma. All these three mutations are the driver mutations, and they are actionable mutations. So if these three are present at baseline, then they would affect our treatment decision. How? Now we are going to see for it. And this is done by NGS. If the patient can afford it, we should go for it. So this is a slide which shows the role of TKIs. So in 2013, we got the first TKI, sorafenib, after a phase 3 trial. And then we get another TKI, lenvatinib, and then these are the multi-kinase inhibitors, and then within the span of 4 to 5 years, we got these selective kinases inhibitors, showing very good results. And in the second line, we have another tyrosine kinase, cabozantinib, and we have in July 2022, June, the approval of dabrafenib and trametinib in the management of RAI, differentiated thyroid cancer treatment landscape. Now in the coming slides, we are going to see the evidence of these TKIs. So this is a slide which shows how we are going to choose which agent and what are the considerations. So in short, we can see that we have multi-kinase inhibitors, the sorafenib and lenvatinib. The main target is VEGF receptor 2. So lenvatinib, sorafenib, and cabozantinib, and all these are backed by phase 3 data. So these are multiple kinase inhibitors, while these we have some selective kinase inhibitors which only work on specific genes. For example, the if the NTERC gene is mutated, then we have 3 agents, larotrectinib, entrectinib, and repotrectinib, and similarly 2 agents for the RET gene fusion, serpercatinib and pralsetinib. And if the BRAF VCE mutation is present, then dabrafenib and vemurafenib are there. So these are selective kinase inhibitors. We can call upon them that these are gene-specific treatment, while the commonly used, they are multi-kinase inhibitors. Along the VEGF2 receptor, they also act on different receptors too, leading to side effects, some also. So now, these are the 2 phase 3 trials, the decision trials and the select trials. So this was the first trial, phase 3 trial for sorafenib, which showed a progression-free survival benefit of 11 months as compared to placebo in the radioactive iodine differentiated thyroid cancer management, and the objective response in this trial was about 12%. While The SELECT trial is also a phase 3 trial in which lenvatinib was compared against the placebo, and over here the median progression-free survival was 18 months, and over here the most interesting thing was that the objective response was about 68%. So this is the differentiating factor, the objective response of 68% and as compared to 12%. We cannot compare the cross trial because these both are different trials. So if we can have a phase 3 trial, head-to-head comparison sorafenib and lenvatinib, then we can see what will be the actual results. However, still the experts prefer lenvatinib as first line, having the objective response of 67% and the median progression-free survival 18 months as compared to this sorafenib, which has a median progression-free survival 11 months and the objective response is 12 months. And the side effects of the lenvatinib are relatively less toxic than sorafenib. These are some of the side effects. The most common is the hypertension, the hand-foot syndrome, and the weight loss and diarrhea. Hypertension is most common with lenvatinib, while diarrhea and hand-foot syndrome are most common with sorafenib, but easily manageable. So we can see that lenvatinib is preferred over sorafenib because of the high objective response rate and relatively manageable side effects. So now we are going to see the second line. So if the patient progresses in sorafenib and lenvatinib, then on the second line, what choices do we have? So there is a phase 3 trial, COSMIC trial, so in which another TKI, cabozantinib, was compared with the placebo. And over here, the median progression-free survival was 11 months as compared to just 2 months. And the objective response in this trial was about 15%. So, and this trial also tells us if the patient progresses on the lenvatinib and sorafenib, then we can see how that disease is poorly progressing. If we do not give anything, look how the patients are progressing very much. So, if patient is affordable, then we can give this TKI if the patient progresses on sorafenib and lenvatinib. This is also a phase 3 trial. So these three are the multi-kinase inhibitor. So in summary, we can see that in first line, lenvatinib is preferred over sorafenib, and in NCCN also lenvatinib is written as preferred category 1, and sorafenib is also a category 1, but with lenvatinib it is preferred. In the second line, we have this TKI cabozantinib. So this is NCCN guideline showing preferred agent is lenvatinib category 1, and this is also category 1, but the preferred agent is this one. And if the patient progresses on these two agents, then we can have another TKI, that is cabozantinib. Now the previous three were the multi-kinase inhibitors. Now the role of selective kinase inhibitors or the gene-specific therapy if the patient is having these mutations. So number one mutation is the RET fusion gene. So if the patient is having a RET mutation gene, then we have two agents, serpercatinib and pralsetinib, and these are approved by the FDA. And what is the data? We are just going to see it. And we can see that these two agents, how they are specific just only targeting the RET fusion gene. This one is more specific as compared to this one. These diagrams show the off-label effects on other targets. So serpercatinib is more specific as compared to this one. And now, this is the data. This is the data. The trial was published in the New England Journal of Medicine, and look at the objective response, 79%. These are the patients which are radioiodine refractory patients, and these are the patients which have progressed upon the multi-kinase inhibitors. And we can see the complete response. One patient, 5% of the patients are showing complete responses, and the disease has been completely abolished, and the median progression-free survival was 20 months. So if we can see if these fusions are positive, they are going to have good treatment effect. So look at these responses. These are the thyroid patients' data, and the papillary thyroid, and these patients are showing complete responses. The disease has been completely disappeared. And these are patients which are radioactive iodine refractory as well as progress on the multi-kinase inhibitors. So another selective gene is the TERP gene fusion. And if it is present, even the TKIs are more promising, backed by this data. This is TERP. TERP is an so this is the trial, the efficacy and safety of Rilotrectin in patients with TERP fusion positive thyroid carcinoma. And look at these responses. Look at these responses. These patients are showing complete responses. Complete responses. And the response, and then in differentiated thyroid cancer, the responses are 86%. So these are unbelievable. If the patient is having inter-gen fusion, and these are the papillary thyroid cancer, radioactive iodine refractory, as well as progressed upon the multi-kinase inhibitors. So if the patient is affording, we should look for these mutations, because these mutations, and if this treatment is available, if the patient can afford it, so they will have good prognosis. This is another diagram which shows that in the differentiated thyroid 21 patient, the objective response rate was 86%, and 10% of the patients were showing complete responses with the progression-free survival 51 months, and the duration of response was 49%. And when this data is seen by the experts, they say it is unbelievable. So, it is the summary of the selective kinase inhibitor. Sulfatinib and pralsetinib, these are the FDA approved for patients with RET fusion differentiated thyroid cancer, and Rilotrectinib and entrectinib, these are the FDA approved for the treatment of the inter-gene fusions. All four agents have significant responsive with minimal grade 3 and 4 toxicity, which is clinically significant improvement over the multi-kinase inhibitors. So, the diagram we can see now, these fusions, if these are present, then we can we should start with them if the patient is affordable and these drugs are available. And after that, then we can see the free first line, looking at their responses and their low side effect. Then we lenvatinib, sorafenib, and cabozantinib. So if a patient can have NGS at baseline, we should look for these mutations at baseline before starting the TKIs. And now, so these are again the NCCN guideline. Lenvatinib is category 1, other agents sorafenib, but it is preferred one. And if these mutations are present, then we should use them as a free first line. And now, the third mutation is the BRAF V600E mutation, and this is the data. We have two agents, dabrafenib and vemurafenib. Vemurafenib in patients with BRAF positive metastatic or unresectable papillary thyroid cancer refractory to radioactive iodine, a non-randomized phase 2 trial, and dabrafenib versus dabrafenib plus trametinib in BRAF metastatic radioactive iodine refractory differentiated thyroid cancer, results of a randomized phase 2 trial. So, here the story is a little different. These are the two agents. These are the objective response rate, 35%, and this agent is showing in the data of also 38%. So if we remember that lenvatinib was showing an objective response of 68%, and while these selective agents were showing response rates of 80%, while this they are showing relatively less responsive. So we can see if these mutations if this mutation is positive, then unlike this, we have put it downside. We will first start with this, if a patient progresses on this, and then we can, as contrast to these mutations, if these are present, then before starting lenvatinib, we would use these targeted agents. And these mutations are mutually exclusive. If this is present, then these two will be not present. And if this is present, then these two will be not present. So this is again the NCCN guideline. We have covered this one. then repetition, this one, and then for patient with BRAF V600E mutation, we can use one of these two agents. But their responses are relatively less effective as compared to these agents. So, in summary, serpercatinib and pralsertinib, FDA approved for patients with wet fusion thyroid cancer, levotrectinib and entrectinib, FDA approved for treatment of TERT gene cancer. All four agents have significant response with minimal grade 3/4 toxicity, while the BRAF inhibitors, the response rate is 30%. So use them at last. Again, revision. And we can see that on the horizon, in the future, we can have better RAF inhibitors in testing as compared to the available one. And there will be we can identify more mutation targeting the RICE mutation and other causes of upregulation. And role of immunotherapy has been disappointing in thyroid cancer, and it is still to be determined. Thank you very much.